Yes, it's not. So I'm going to just talk to you a little bit about some research that our team did down in Gambella in Ethiopia. And it's not sort of specific to MAMI, but it's all about maternal, infant and young child feeding, practices and support for behaviour change in the same context that we're implementing MAMI. So just to give people who aren't familiar with our work there, so it's Gambella, so it's a refugee context in Ethiopia where we are supporting South Sudanese refugees across 2 camps and we are one of the UN partners for nutrition. So we have a whole package of nutrition management interventions, including prevention and curative care, spanning BSFP, TSFP, OTP, stabilisation centre outreach, MIYCF, and other sort of small-scale supportive interventions like micro-gardening. So the research I'm going to speak to you about was conducted in that context, and it's all about trying to engage men to a greater capacity in MIYCF as well as targeting women. So most of us working in this space are familiar with behaviour change and the various steps of behaviour change. So starting with awareness at the bottom, and then the acquisition of knowledge, and then comprehension and intention to actually carry out or change one's behaviour, resulting in actual action. But the most important step is the actual maintenance of that. So in terms of today's example, as I said, it was in Ethiopia, and what we've been trying to do is trying to get a sort of greater degree of resonance and behaviour change achieved in these target populations with regards to maternal, infant and young child feeding practices. So in Gambella, like many other contexts, the burden of childcare is shouldered by mothers predominantly, when in theory it should be both fathers and mothers who have equal responsibility in ensuring the healthy growth and development of their children. So how do we actually support the adoption of positive behaviours or practices? So evidence shows that empowering women significantly contributes to the improvement of child nutrition and health in general. So we know that from years of experience. However, policy and interventions are very often overlook the key influences, and given their ability to actually control or influence the behaviours of others, they're obviously incredibly important. So most interventions that support child growth and health are actually attended by women. That's certainly true in our context in Gambella, which means the opportunities to engage with those key influences is limited. And yet the distorted attitudes of many societies towards women have prevented women from actually participating in decision-making. And this is particularly pertinent to women's reproductive health, women and child nutrition, and also control over things like economic and financial resources in the household, which are used to access all of those things, health, nutrition, etc. So we've got to make sure that we understand family and community dynamics if we're going to be able to successfully influence. Okey-doke. So people can't just be told what they should be doing with an expectation on our part that they'll make all the necessary changes. Instead, people need to be brought along in the journey, all those steps that we looked at in the second slide. So people need to be made aware of the issues. Then they need to be provided with the requisite information and allowed to digest this. So that includes the sort of first couple of steps, the awareness and the knowledge stages. People then need to be shown how to take it to how they can achieve these changes. So that includes the contemplation and often the intention stages. And then there also needs to be support in the creation of an enabling environment within which change can be made. So this includes engaging with key influencers and the community at large. Then the action or actions, if there are multiple actions, can be trialed, practiced, repeated, and ultimately, we hope, maintained. So when targeting any group, in this case, it's women as the primary agents of change to adopt positive care or feeding practices, it's imperative that the key influencers, and in this context, it's husbands or partners, are capacitated to play an active role in helping to elicit and therefore support sustainable change within their homes or communities. So in Gambella, in an attempt to create this enabling environment, in July 2021, what the team did is we already had mother-to-mother groups that had been implementing, supporting MIYCF messaging, counselling, peer support, etc. That was all mirrored in the static health facilities and through MAMI and through CMAM programs, etc. So in addition to that, 200 lead fathers were trained to run father-to-father groups across 2 refugee camps. So a total of 100 groups were established, so 2 lead fathers per group, in August of last year. And each group consisted of 2 team leaders and then between 10 to 15 peer members, peer males. So the team leaders were taught how to engage with their members in discussions about childcare, and they were provided with health education, but in an interactive, participatory manner. So it wasn't just sort of didactic style education. There was lots of practical based initiatives like cooking demonstrations, that sort of stuff. So they met once a week, and each of the sessions lasted around 2 hours. So the hypothesis was that by increasing engagement of targeted males from households with young children around appropriate care and feeding practices of children and women in their households, this would create an enhanced enabling environment for active behaviour change and sustained positive practices. So that was the hypothesis from which the team were working. So to determine the impact of these father-to-father groups in helping to elicit behaviour change around maternal, infant and young child feeding, a piece of qualitative research was undertaken in March of this year, of 2022. So focus group discussions were conducted with members of the father-to-father groups, but also members of the mother-to-mother groups, so men and women from same families. And key informant interviews were done with health counsellors to assess 1, perceived changes in knowledge and practices, 2, the acceptability of the approach, 3, explore the scope for alternative points of contact with fathers, and 4, to explore different modes of engagement or communication to support improved MIYCF. So in terms of, there were lots of findings, it was really quite rich. So in terms of the findings, prior to the participation in father-to-father groups, fathers said they had little appreciation of the health and nutrition needs of wives and children, or the challenges being faced by them meeting those needs. So they just didn't appreciate, additional requirements, especially when women were pregnant or lactating, things like additional iron requirements during menstrual cycles, or children, going through rapid growth. They just thought they're little, they don't need much. Clearly diversity wasn't something that was well understood at all. Second, the establishment of father-to-father groups, it also enabled men to actually understand what their wives were learning or what they were engaging with through the mother-to-mother, the female peer support groups that were already being implemented. They said previously there was resentment of the women's time spent away from the house when they were engaging in these mother-to-mother groups, and they just didn't know what they were doing. So just that awareness was also incredibly important. All parties confirmed the initiative was highly valued, resulting in an improved appreciation by fathers of the needs of their families, the importance of appropriate feeding and care, plus there were reports by mothers of subsequent male engagement in MIYCF. So husbands, for example, spending more time with their children or supporting child hygiene, tending to children when women went off to go and fetch water or firewood, so they didn't have to traipse children along with them or carry them, engaging in antenatal care appointments, which hadn't happened previously, taking sick children to health facilities themselves and not leaving that to be a female specific job. Also engagement in screening and using MUACs, and even reports of men cooking, which again is sort of culturally not done in that context. In which most of these things men would never have engaged previously, or only would have undertaken if the woman herself was sick and there wasn't somebody else, a sister-in-law or mother in the household to undertake those gendered, what were perceived as gendered practices. Number 4 was, despite the many encouraging reports, almost all male respondents articulated facing deep-rooted sociocultural barriers, constraining community acceptance of engagement in many of the practices that were deemed to be women's work, where they feared ridicule and social isolation. There were multiple reports of men outlining that there would be a willingness to adopt new behaviours if they saw others doing the same, but they didn't really want to sort of stand out on a limb and do it by themselves, as if others weren't seen to be following suit. Number 5 was, due to this stigmatisation, we saw an incredibly high attrition rate in the establishment of the group. So as I said, they started in August last year with 100 groups established with between 10 and 15 members per group. And after 8 months, only 26 of those groups were still actually meeting and actively engaging. So obviously massive reduction in community coverage. The model as it was had not been designed to address the wider sociocultural norms, only practices within the specific number of households that were targeted in the pilot. So the attrition is reflective of the need to have a wider enabling environment to support not only the primary agents of change, the women in this case, but also the key influencers, the men in this case, so that they could feel capacitated to support change. The penultimate finding was wider community engagement with greater transparency to elicit acceptance is needed, in consort with wider coverage combined with different modes of engagement. So again, anyone who works within social behaviour change knows that we have to have repeated points of contact. There needs to be a lot of practical based engagement. And there has to be engagement using different modalities, different modes of engagement to try and maximise outcomes. So opportunities that were flagged, that people flagged, included the use of respected church leaders advocating for the acceptance of males to play a critical role in MIYCF practices. There was also the use of community champions. People said this would be useful, or respected members of the community using testimonials or the likes to stimulate a desire to change as people recognise themselves in these individuals. There was the use of videos. So people in this context have been exposed to the use of global health media videos that are used through the MAMI program. So they suggested use of videos showing prominent global figures from other cultures engaging in MIYCF. They also said targeting of adolescent males and younger men prior to marriage for inclusion in these sorts of initiatives would be really, really valuable. So trying to get possibly more malleable minds to elicit change before people become entrenched in their ways and values. They also stated a greater interactivity of sessions, i.e. participatory community kitchen demonstrations, they said would be useful. And lastly, encourage experience sharing and intergroup competitions to encourage behaviour change. So these are all things that have been, that was the research was able to find through these focus group discussions and key informant interviews. And lastly, we've got health workers confirmed that women continue to struggle, even in those households where those father-to-father groups were continuing to function, and where there was, where there was good engagement. Women continued to struggle to find the time in their already busy schedules to practice all of the different optimal feeding and care practices that ideally would be upheld without familial support. So they needed familial support, be that from their husbands or from other members of the family, in order to actually achieve all the different things that they're being told they should be doing in order to create an environment for their families to both survive and thrive. So I just wanted to very quickly, last couple of slides, just give you, so these are two examples, two case study perspectives. The first perspective is from a father who was able to support behaviour change. The second is from a woman whose husband wasn't able to support behaviour change. So I'll just read what they said. So this is the father who was able to support behaviour change in the sphere of MIYCEF. He said, before joining the father's group, I only used to fetch fish for the family, and I take the children to the hospital when they are sick if their mother is not well. We didn't do indoor activities. If my wife is sick, I will call her mother, my sister, or my sister-in-law to help us with cooking and taking care of the children. I never took my wife or went with her to pregnancy follow-ups. But after joining the group, I've attended one or more of her follow-ups and also taken her to the health centre during labour when my wife gave birth to our youngest son a month ago. Now I know what a mother should eat during pregnancy and lactation. I also know how a child should be fed of a respective age, and how to keep the hygiene and sanitation of my children. I never followed what my family ate. I only used to care about myself. Very candid. Now I am supporting my wife in any way I can. So that's someone who previously wasn't engaged and subsequently did engage. So this is a woman's perspective whose husband has felt that they were unable to support positive behaviour change. So she says, our culture is too tight and stressful. It encourages men not to do anything. Everything is our responsibility, including building a house. Women in our community won't let their husbands to help them. This is not because they hate being supported, but because the community doesn't accept it. If the community sees a man cooking food or cleaning his kids, the community will isolate him. Even if they don't isolate him, he won't be able to tolerate the rumours. So the women won't allow their husbands to support them with childcare, and the guys don't want to get involved in the father-to-father support groups, fearing the rumours. So it's really interesting to actually, put that in a sort of human, personal perspective, to see what sort of barriers people, individuals, communities are all up against in terms of tackling what, often are sort of very, simplified or perceived as sort of easy things to achieve. So in terms of the learning and recommendations, to support the change of any practices that are influenced by other people and or by sociocultural norms, and that's pretty much every context in which we work, we need to create a broad enabling environment. This means looking at who you want to make the changes. So these are the change makers who are going to actually influence the change. The key influencers, but also the other people, the community, who play a role in the social system that will influence the ability of target groups to actually make these positive changes. So in this instance, in the example in Gambella, we're targeting feeding and care practices commonly undertaken by women, where women need the support of men. So that was the final recommendation, was that women couldn't do it without familial support. But in turn, men also need the support and validation of the community. Therefore, the approach needs to address stigmatization to allow men to freely and actively engage with their families to support optimal maternal and child care. Overcoming such constraints will not only facilitate men's involvement, but it will contribute to enhanced gender equality and sustained positive change in target communities. So all these elements are interconnected and interlinked, and we've got to address them all synergistically if we are actually going to create change, and that change has any chance of being sustainable. So that was the end of the presentation.